approach to headaches. Okay, so it starts with the rationale. Every objective of the MCCQE1 starts with the rationale. And the rationale is what is going to guide you in your studies. It says that headache is a common clinical presentation, and patients with headaches due to serious or life-threatening conditions must be differentiated from those with benign primary headache disorders. So that's the very first thing you have to keep in your mind. In your exam, they will want you to know some causes of headache which are life-threatening and some causes of headache which are benign. So I have a question. Who in the class can tell me, assuming you are reading this rationale and then you come across this particular point, what are some life-threatening conditions which cause headache? Can someone help me?
Subarachnoid hemorrhage.
Subarachnoid hemorrhage, beautiful.
Meningitis.
Meningitis, beautiful.
And encephalitis.
Encephalitis, beautiful. You see, so now the topics you need to review are already coming out just because you read a rationale.
Carbon monoxide poisoning, is carbon monoxide poisoning can be included in there?
Exactly, carbon monoxide poisoning can be included in there, but it will also come under emergency medicine and toxicology, right? So that's very powerful.
Giant cell arthritis.
Giant cell arthritis, beautiful. And you realize that while we are going through the presentation today, we'll be dealing with all those topics because the rationale says so. Okay, so the key objective is giving a patient with headaches, the candidate will diagnose the cause, the severity, and complications, and will initiate an appropriate management plan. Particular attention should be paid to differentiating between causes of headaches differentiating between benign causes of headaches from potentially serious causes. So I have a question. Since we mentioned some of the potentially dangerous causes of headache like subarachnoid hemorrhage, meningitis, encephalitis, carbon monoxide poisoning, what are some headache causes which are also benign? Can somebody help me? Benign.
Cluster headache, migraine, tension headache, which is the most common.
Cluster headache.
Beautiful. So you realize that now, when I'm studying for this exam, I already have a framework. If I'm even picking topics from Toronto Notes to study or Master the Board or whichever book you decide to read, you realize that now you have a framework you're going to use. So you pick the benign causes. You can list like medication overuse headache, migraine headache, cluster headache, tension headache. The life-threatening causes, meningitis, encephalitis, carbon monoxide poisoning, even intracranial space occupying lesion, right? All these. So then you can group them into two because the objective says that is how you have to approach the whole thing. Now, after the rationale and the key objective, you realize that then they take you to what you call an enabling objective. So the enabling objective, the first one says something interesting. It says that given a patient with headaches, the candidate will list and interpret critical clinical findings, including symptoms and signs that indicate a need for urgent brain imaging and a referral for specialized care. This is the first enabling objective they start with. So you realize that, look, if you are studying the concept of headaches, you've got to make sure that you are hitting the bullseye. This is not a time to do a laissez-faire reading. This is a time to go straight. Okay, it looks like from the rationale to the key objective to the enabling objective, the medical council is hitting on serious causes of headache. So now, can somebody help me? What are some of the red flag symptoms that if I see in a question stem or if I see in my patient will draw my attention to the fact that this headache is serious?
Fever, loss of consciousness, meningitis symptoms,
confusion,
papilledema, vision changes, and
early morning headaches.
Early morning headaches, sure. What else? So you're saying
Onset of headache.
Next,
sickness.
Okay. So let's look at it. What are the things which will cause me to be concerned that this patient's headache, I shouldn't play with it? This patient's headache, I should probably get a CT scan, or I should call a specialist. Number one, if anybody comes to me with headache plus fever. Okay, so I have a question. Headache plus fever. What are some of the differential diagnoses which can come into my mind?
Meningitis, encephalitis,
Encephalitis.
Meningitis, encephalitis, what else?
Cerebral abscess.
Cerebral abscess, beautiful. Okay, what about headache plus vomiting?
brain
Tumor.
pressure,
Brain tumor, beautiful. Okay, what about headache plus neck stiffness?
Meningitis.
Subarachnoid hemorrhage.
Hemorrhage, beautiful. Okay, what about headache plus pregnancy?
eclampsia,
Preeclampsia.
Yeah, beautiful. What about headache in an immunosuppressed patient?
Encephalitis.
HIV. Toxoplasmosis.
Toxoplasmosis. What about even brain metastasis?
Yeah.
Right? So doctors, now you realize the whole thing. So if I'm going to remember this, I'm going to remember Snoop Dogg. That's guy who is a singer, right? Snoop Dogg. If you remember this guy, if you watch pop culture a lot, this guy, he's a singer in the pop culture and he's very popular. And we are using him to remember all the bad stuff which can happen in headache. All right. So whenever you have a case of headache, remember Snoop Dogg. Snoop. S stands for systemic illness. And we've already been able to map things out. Fever plus headache, meningitis, encephalitis. Vomiting plus headache. I'm thinking about the life-threatening ones, board exam style. Vomiting plus headache, I'm thinking about intracranial space occupying lesion. Neck stiffness plus headache, I'm thinking about subarachnoid hemorrhage, meningitis, encephalitis. Pregnancy plus headache, I'm thinking about preeclampsia, eminent eclampsia itself.
Of that indeterminate range, or you're much, I'll say this.
All right. Immunosuppressed patient with headache. I'm thinking about toxo, I'm thinking about brain metastasis. Now, somebody also mentioned altered mental status. Doctors, please, is the class going well? Because I want us to take our time and pick up the pieces so that we can approach this objective very well. Is that okay? Is it helping? Is it helping you?
Yes.
Beautiful. Good. So another red flag I want to watch out for is altered mental status. So headache plus altered mental status, red flag. Headache plus focal neurologic signs, red flag. If I look into the person's eyes, headache plus papillary edema, headache plus altered mental status, what diagnosis should come into my mind?
Raised intracranial pressure.
Raised intracranial pressure, what else?
Meningitis, encephalitis.
What else? It could even be subarachnoid hemorrhage, or even a stroke, right? Good. What about focal neurologic signs? The same thing we talked about. Intracranial space occupying, stroke, all those things. What about papillary edema?
Hypertension.
Severe hypertension. Okay, what about headache plus seizure? So I have a question. Wait. I have a question. If you have a 24-year-old, exactly. If you have a 24-year-old female who comes to you, has headaches, and has a seizure, what is the next best test you will do?
Pregnancy test.
Pregnancy.
Pregnancy test. Beautiful. So doctors, you see the way, even with one slide, we are trying to break it down. I really want us to start thinking like a Canadian trained physician. We learn with patterns in Canada, right? Okay, good. Headache, which is new. You know, if you have somebody who has been having headaches since they are adolescents, sure. But you have a patient who has headache, which is new and sudden in onset, you are concerned about it. As well as a patient who has severe headache after trauma, headache which awakens the patient from sleep, early morning headaches, and then headaches which are worsened by Valsalva maneuver, that should also cause you some level of stress for you to say that, oh no, what am I going to do about this? And then if the patient also has prior headache history, but then that headache history previously is totally different from the headache history the patient is presenting with right now. The patient will say, oh, doctor, since I was an adolescent, I've always had migraines, and whenever it comes, I can take Tylenol and I can go around my stuff. And then now, all of a sudden, this headache is different. Then you know that there's trouble on the mountain. Doctors, can I proceed now? So we know the red flag things that if I see this in a board exam, boom, I'm going to either get, some serious investigation going or something else. Okay, good. So red flags to know of head. Temporal arthritis. Because remember that we are trying to map the cause of the headache with the next best step, right? Temporal arthritis. I have a question. How will a patient with temporal arthritis present? In one sentence. How will a patient with temporal arthritis present?
Jaw claudication.
Jaw claudication, what else?
Unilateral headache.
Unilateral headache, what else?
With pain
And then-
upon combing.
Palpation of the head.
Scalp tenderness.
Scalp tenderness. Yes.
Reduced visual acuity, and
Okay,
even
sure.
it may lead to
Proximal muscle weakness.
Okay, sure. Okay, so let's hold it there. So if I have like a 56-year-old gentleman who comes in with some shoulder weakness, he has pain when he's combing the hair, he has tenderness on the right temporal region, and has started developing visual blurring. What is my next best step?
Give a steroid.
High dose
Okay.
prednisone.
Give a
High
steroid.
dose.
Wait, doctor. So you give a steroid first before you even go on to do the investigation. Because if you want to wait to get the results of the investigation before you treat the patient, you're going to be in trouble. So your next best step is to give steroids. After you give the steroid, then you can take your blood sample for what investigations are you going to do? ESR, imaging. You can also do temporal artery biopsy. And then what is the next step after that? I give my steroids, I take the blood sample. What is my next step? This patient will see
Refer to a neurologist.
a neurologist, an ophthalmologist, and a rheumatologist right away. Three people who has to be seen. But then if I see this patient and he comes in with the symptoms, my next best step is give steroids. Give steroids even before you do all your workup. Because if you don't give the steroids, that patient can go blind. So temporal arthritis, please. This is temporal arthritis made ridiculously simple. Quick review. Subarachnoid hemorrhage. How will the patient present? Severe headache. The patient may say, this is the worst headache in my life. Some textbooks will describe it as thunderclap headache, right? The patient may collapse and they may regain consciousness. What's the next best step? So after you've managed the ABC, you want to request a head CT scan because that will help you to know if there's a bleed. If the head CT scan is not very specific, you want to do a lumbar puncture. Now, head subarachnoid hemorrhage. When you do a lumbar puncture, what will you see on the lumbar puncture? Can somebody tell me?
Xanthochromia.
Xanthochromia. Beautiful, beautiful. That is a yellow tinged spinal fluid, right? Okay, good. Okay, meningitis. Meningitis, we've learned that it's a combination of headache with fever and some other things you want to know. Has the patient come in contact with anyone who is sick? Has the patient traveled to tropical region? Does the patient have any neck stiffness, right? Has the patient been immunized, right? You want to find out about all those things. Has the patient been immunized? And then you also want to, has the patient been immunized? Like temporal arthritis, with meningitis as well. If you suspect meningitis in a patient, give antibiotics before you confirm the diagnosis. If you suspect meningitis, give antibiotics before you confirm the diagnosis. Now, while you are giving antibiotics, what other medication can you give as well? Can somebody tell me? And why?
Steroids.
Steroids.
Dexamethasone.
Why?
Pneumococcal.
Prevent hearing impairment.
Prevent hearing loss. Okay, so let me say it again. If you have a patient who has symptoms of meningitis, fever, neck stiffness, headache, decreased level of consciousness, positive Koenig's sign, or in a child, positive Brzezinski's sign, start your antibiotics. Most of the time it's ceftriaxone plus vancomycin. Give some steroids. Okay, I have another question. If you have a patient who presents with the same symptoms we talked about, neck stiffness, headache, decreased consciousness, and you find some vesicles around the lips,
HSV.
What's your diagnosis?
Herpes simplex virus.
Herpes simplex. So what is it meningitis or encephalitis? The patient might have developed encephalitis. And in that situation, you give an antiviral medication. So please know how you're going to pick up all these patterns so far as a board exam is concerned. Okay. So now, if you have a patient with
Question?
question. Ask your question, sure.
Yeah. I want to get a clarification on the distinction between tuberculous meningitis and subarachnoid hemorrhage on lumbar puncture, especially the color.
There's a whole lecture on lumbar puncture. There's a whole lecture on it. And those in the program I've already made available, but we are going to re-record it again for you again. But if you want, I will take you there and then we'll just look at it after the class today. When the class is done, we can look at it. Okay.
All right. Thank you.
I just don't want us to sway from what we are trying to build, right? So, and then you also realize that in the various cases of headaches, like most of the MCC objectives, one other thing they also want to stress on is history. What will you want to find out from history? So if you have a patient who has headache, what are the historical things you want to find out? Number one, is this your first ever headache? Number two, is this the worst headache you've ever had in your life? Number three, is it steadily worsening over days, or is there a significant difference between this headache you're having and some prior headaches you've had in the past? Number four, what was the duration of the headache you're having? Number five, what is the severity on a scale of 1 to 10, with 10 being the worst pain and 1 being the least pain? What are the associated symptoms? So that's what we said. Headache with fever, headache with papilledema, headache with focal neurologic symptoms, headache with seizure, right? You want to find out. If you have a patient who has sudden onset of headache, which begins during exertion, maybe the patient says, doctor, the headache started when I was in the washroom, when I was pooing, like passing stools, or when I was coughing. Think about it. Sudden onset headache, which comes on during cough. Think about subarachnoid hemorrhage. So please write it down. Sudden headache, it comes on during cough. It comes on during defecation. It comes on during micturition. The patient is peeing. At times, it even comes on during ejaculation. Think about subarachnoid hemorrhage. And then the location of the headache, which will also be given, will also tell you or give you a clue. Headache is unilateral. Think about migraine headache. Think about temporal arthritis. Headache is bilateral. Think about tension type headache. Headache is occiput and nuchal. Okay? Think about subarachnoid hemorrhage as well. Remember, your approach to the Medical Council of Canada exam, always think about the things which will kill the patient first. So you realize that whenever I'm mentioning diagnosis, I don't go talking about migraine headache as the first thing. I will talk about the things which will kill the patient. Subarachnoid hemorrhage, meningitis, encephalitis, intracranial space occupying lesion, severe hypertension, carbon monoxide poisoning. Even before I come to migraine headache and medication overuse headache and all those things. Other things you also want to find out are headache which is associated with syncope, headache which is associated with altered loss or loss of consciousness, headache which is associated with confusion, headache which is associated with neck pain and neck stiffness. Headache, which is associated with persistent visual disturbance. Headache plus fever. We've already looked at the differentials. Headache plus seizure in a woman of her reproductive ages who is not known to have epilepsy. That headache is pre-eclampsia until proven otherwise. You need to do a pregnancy test. And in that situation, don't just do a urine pregnancy test. Do a serum beta HCG. Please. Doctors, are we okay? Are we all on the same page? Okay, good. Headache with any visual change or eye pain. Think about glaucoma. Think about iritis. Headache with jaw claudication. Headache when the patient is trying to comb the hair. Think about temporal arthritis. Headache with congestion, nasal discharge, facial pain. Think about sinusitis. All right. So now, another form of headache you want to pay attention to. If the patient's headache is pulsatile, boom, 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 and it has lasted from 4 to 72 hours, it is unilateral. It is associated with nausea and or vomiting, and it is disabling. The patient wants to lie in bed, in a dark room. Think about migraine headaches. Doctors, please, can I proceed? So please, look, by the time we are done with this lecture, you should be able to deal with headache in all its forms and arrive in glory so far as headaches are concerned. All right? Okay. So, other things you also want to find out about in the patient who is having a headache. Are you taking any medications like nitroglycerin? Are you using any analgesics for a long time? Because at times, some people can get a rebound effect because they've used analgesics for a long time. We call it analgesic-induced headache. Monoamine oxidase inhibitors, MAO inhibitors, and anticoagulants. Okay, so I have a question. If you have a patient who is taking warfarin and comes in with severe headache, what's your differential, or what's your topmost diagnosis? Warfarin patient taking warfarin with severe headache. What are you thinking about first?
Intracranial hemorrhage.
Intracranial. Beautiful. Now I have another question. You have a patient, you are in the ER, the patient is brought. The patient is a long-term care facility patient. The patient fell, but you also realize that the patient has atrial fibrillation. The patient is on rivaroxaban. What investigation would you request?
Non-contrast CT.
What do you say?
Non-contrast CT of the brain.
That's it. If so, in other words, if you have a patient who is on blood thinners and that patient has a trauma to the head, you request a non-contrast CT of the head. Please don't forget that. That can save you from a lot of trouble. Headache from toxic exposure, especially, maybe the patient was close to a generator, the house had caught fire, and the patient was found, and the patient was pulled out by the fire service, and then now the patient is complaining about headache. Sure, we don't know whether the patient hits the head. So, intracerebral bleed, subarachnoid hemorrhage, epidural hematoma, subdural hematoma, all those things are differentials. But one differential you don't want to miss, in headache in a patient who was in fire, or like the house had caught fire, or the patient was in the garage, it's carbon monoxide poisoning.
Carbon monoxide poisoning.
Yeah, carbon monoxide poisoning. And you also want to find out, has there been any previous neuroimaging done? Like any head CT scan done, any MRI done as well? And are there any other comorbidities? A patient who has known breast cancer, known lung cancer, who has developed severe headache, both. Think about brain metastasis before you even think about any other thing. At times it's difficult for us to break bad news to people, but you always have to think like that. What can kill the patient first? And you also want to find out, is there any family history of migraine headaches? Is there any family history of subarachnoid hemorrhage? Now, I have a question. What in a patient's family history will draw your attention to the fact that could each patient have subarachnoid hemorrhage? What is one prominent family history? And it is not in the brain, it's in the abdomen.
History of
Polycystic kidney disease.
Exactly. Doctors, now, are you seeing the way we are drawing relationships?
We didn't hear that.
I'm saying, are you seeing the way we are
Polycystic kidney disease.
the way we are drawing relationships between concepts? That's how you have to think.